In this video, we will begin exploring the OT Generalist approach to addressing driving. We had the pleasure of sitting down with 4 occupational therapy generalists who are currently making a difference by addressing the occupation of driving in their current respective practice settings. Moreover, we aim to demonstrate how the OT Generalist approach can be applied to various practice settings, including acute care, inpatient, and outpatient services. By the end of this video, we hope you recognize the accessibility of addressing driving in your current practice setting and feel empowered to integrate this vital service into your occupational therapy practice. Meet Jeff. Jeff is an occupational therapist in the Southeast Pennsylvania area who works primarily with elderly patients in the inpatient acute care hospital setting. They often deal with strokes, trauma, general medical, surgical patients, and we ask him why it is so important to start talking about driving in the inpatient setting.
You know, I hear exactly where you're coming from, and some people are probably thinking, well, why are you talking about it in the hospital? That seems very early. But I think, as an occupational therapist in the hospital setting, I think it's the perfect time to start talking about it because other disciplines here in the hospital aren't addressing it. It is definitely something that occupational therapy can and should address. And we actually may be one of the only healthcare workers that starts to bring up this topic before the patient goes back home and kind of continues on in their daily activities. We may be the only one that has even talked about this with them or started to think about it. And if we don't mention it in the hospital, I think we're really missing an opportunity to either keep these patients independent and mobile in the community, or we may even be putting them at risk by not mentioning it because they're going to continue to drive and they didn't really know that they had a problem or something that should be focused on moving forward.
What strategies do you use in determining driving risk?
We focus on the medical piece, okay, making sure that they're medically stable and ready in their disease process and their, as far as their traumatic injury goes or whatever the case may be. So we look at the medical piece. We're also looking at just their physical ability to, get up and walk or see what their balance is, looking at those kinds of things. But then when we start to get into a little bit more of like standardized assessments, we're looking at vision and cognition. And we have a few assessments that we use in those areas. And those have all been studied and researched with the driving community. So we know that, we have scores that we can correlate to their performance and kind of lets us know how they would fare behind the wheel, at least with those skills of driving, okay? Because obviously in the hospital setting, we're not able to get them behind the wheel. That's not our role here, but we're measuring like those specific components and starting to talk about driving.
What recommendations do you provide at this stage in the rehab process?
Work with that. Well, we'll do the assessments with them and figure out if they are at, a moderate risk, a high risk, or if they have, a normal level of risk. And if they're kind of in the middle or they're really like a high risk, we can tell them that we would recommend that they hold off on driving for now. And then we'll go back and have a conversation with their physician, or whether it is that we just have a very honest conversation with the patient and with their family and their support system to let them know they should not be driving right now. They should hold off on that and maybe have some family or friends help them with that community mobility piece until the doctor can relook at them again, or that they have follow up with therapy to work on these skills, or even with a driver rehab specialist if that fits.
Have you faced any difficulties with reimbursement or insurance?
I would say in the hospital setting, it's not all that much of a barrier in the hospital setting because in the hospital, the hospital itself is paid in like DRGs, so the diagnostic related groups. So the hospital will get a lump sum of money depending on what the specific diagnosis is for that patient. And then we provide the care that we see fit, and the hospital just gets reimbursed what they get reimbursed. So it's not a direct cost to the patient. So here in the hospital, we can kind of lump that into all the rest of their care.
In these next series of clips, we talk to Colleen. Colleen is an occupational therapist who has been practicing for about 8.5 years. Currently, she works in the acute inpatient setting where she sees a variety of diagnoses, including neuro, stroke, TBI, spinal cord, and cardiac issues, with the population primarily consisting of older adults. We ask her for her approach in addressing driving risk.
I think the biggest thing is that we need to make sure we're asking at our initial eval, is driving an important part of your occupational routine? Is this a goal you want to address? Then we want to make sure that we're adding those goals in from the start, and then we're addressing them as they move through their plan of care.
What assessments do you typically use at your workplace?
So we place a large focus on their IADL performance. So we really look at what they do in terms of how they perform with their laundry routine, their medication management, all those tasks that take kind of like a higher level executive function. We really look at those, and then we pair it with the trail making A and B, Snellgrove Maze test, rapid pace walk, MOCA, and trunk and neck flexibility assessment. So that's kind of like our go-to norms are looking at our IADLs, looking at those screening assessments, and then just in general, looking at kind of our clinical reasoning and clinical thought. If we're seeing some kind of like red flags in terms of performance skills with the ADLs or the IADLs, it kind of just triggers us to say, okay, you know what, they would benefit from maybe working with outpatient therapy services to look a little bit further into this before they maybe return to driving or community mobility.
What is your approach to discussing driving at an acute inpatient level?
Because driving is so important to many of our clients, and it's always, well, not always, but sometimes a hard subject to approach. I find that a lot of times they almost get defensive when we bring it up. So I really try to educate them and let them know what our role is as an OT. And it's really just to maximize their performance in this highly valued occupation. It's not to say you can't drive, you're not allowed to return to the road. Like, no, we want them to stay as independent and on the road for as long as possible. So I just try to frame it like, no, I want to capture all of your strengths. I want to capture all of your abilities. I want to kind of screen where you're at now so I can make recommendations to your care team on where you can go next, who you can see, because we want to help you stay independent. We want to get you on the road. We want to make sure all your transportation and community mobility needs are being addressed.
Having heard from the inpatient occupational therapist, let us now delve into the perspective of the OT who works in the outpatient setting. Nicole is an occupational therapist who has been practicing for about 11 years. She primarily works in an outpatient setting with neurological patients, including those who have experienced stroke, brain injury, and mild cognitive impairments. We begin by asking her what OT's role is in the outpatient setting.
A lot of patients with their diagnosis or why they're coming to occupational therapy and outpatient, we're kind of the end of the line. Like, we're the last step for therapy before they kind of go out into the world their own way. So driving, typically has been kind of put off, from the acute setting to rehab setting to now, okay, now what do I do now that I am outpatient? How am I going to move on? So I think outpatient is a specific area that needs to address driving and the idea of community mobility further.
How does the conversation of driving typically start for you?
It's usually honestly the first thing that they will ask when they come in for an evaluation, like, I'm ready to go, now what? So kind of looking at the specifics on why they haven't been able to get back to driving, and then kind of breaking it down to be like, okay, it's either the physical, the cognitive, the visual components to it. What is it that we need to address to further go with it? A lot of times it's the back and forth. Well, I've always driven. I've never had any accidents, or I've never had any problems in all my years. Why is someone telling me now that I can't just because I had a stroke or I was hospitalized? So it's a lot more of teaching of what could be the concerns or why we have to further evaluate different areas.
Can you give us an example of some outpatient interventions you may use to prepare your patient's return to driving?
So for like, if a patient is noticing trouble with their visual scanning or having trouble with their, their visual fields, we have the Dynavision in outpatient at my clinic. So we'll put them on and do different areas. We might have them starting seated and then progressing to work on more of the balance, more of the higher level, doing that standing. And then we can actually add in different components to make it more of a divided attention task. So although it's a specific driving skill, it's going to follow up in everything that they're doing to make sure that they're safe and functional doing everyday tasks as well.
Have you faced any difficulties with insurance or reimbursement?
For in the clinic stuff, no, I have not had any issues with reimbursement because we can tie it to functional tasks within the clinic for insurances. I know it's always a concern when I'm recommending an on the road test that patients are very much more hesitant because of the cost and everything like this, which it's a common theme, but I think again, the understanding, teaching them about the insight, having the family be aware of why we're doing it and the safety concerns. Half the time the family's willing to put it up without any questions. So I think that's the way to work on towards the reimbursement for that on the road. But yeah, in the clinic, I have not had any issues with reimbursement for in the clinic stuff.
What recommendations do you typically provide your clients during your sessions?
But I think it's a lot of education on what has changed since, their diagnosis or since their hospitalization. Really stressing that it's not just them they could be putting at risk, it's everybody else. And I tend to kind of come back and be like, would you be concerned with having, a grandchild in the car with you? Or is it something that you feel comfortable doing? It's a lot of insight and awareness education that is always hard, especially in the neurological and the brain injury realm of patients. But I think just that reiteration of not trying to take it away from you, like my goal is to get you back to driving because I know that is so important, but I want to do it safely because I don't want anything else to happen and you don't want anything else to happen. So I think trying to be more the agreement side with them rather than trying to take things away and having it be like, well, I'm telling you, no, this is how it is. It's more trying to work with them more.
Our final interview is with Melissa. Melissa is an occupational therapist who has been working with the Lehigh Valley Health Network for about 20 years. She works primarily with the adult outpatient rehabilitation facility, specializing in the neurological population. We begin by asking her about occupational therapy's role in driving.
OT has 100% ability to address this role in community mobility. Even without the driving simulator adds a nice piece to it. But again, it's not like driving on the road, and even the evaluation we do for driving risk is very comprehensive. We use the Generalist resource for integrative driving, the grid, that categorizes people as green, yellow, red based on certain things. And it's really nice to be able to look at the physical aspect, the cognitive aspect, and all those kind of things and how it kind of relates to driving.
How do you assess driving in your workplace?
So we have the STI Sim driving simulator. So we use it for our readiness to drive, or not, our driving risk assessments, I should say. Driving risk assessment, I use it as part of the evaluation for the brake pedal reaction time, basic vehicle control. A big thing individuals always tell me is they're like, this is nothing like driving a car. And I say, I know, I'm not assessing your ability to use the simulator. It's new equipment. I'm assessing your ability to know that you have to stop at a stop sign, to know that you have to stay in your lane, to try to be cognizant of what the speed is, to look down and say, oh, I don't, this doesn't feel like, I feel like I'm starting to go faster, because you're not getting like the haptic feedback that you would get when you're in a car. So I do explain that to the individuals that I put on the driving simulator, because they get very upset when they have a hard time using it. So I do explain that to that, and I write it that way in my assessment too.
Could you provide a final statement on your experience learning about driving in your workplace?
I was really, really intimidated when they talked about this driving risk assessment program. It was something newer to me. I was nervous. The evaluations were new. We kind of like worked closely with Susie and with AOTA to like come up with a nice format. They took me longer than my normal evaluations did because they were new. And I guess I was also nervous about making like a wrong decision, or I was worried about liability. I was worried if I only classified someone as like a mild risk and something happened, like it would come back to me. So I think for me, yeah, it was just anxiety and being nervous about it. But now that I've done it, and I do it quite frequently, these assessments, I have really kind of develop my own system and my own pattern, and I just feel really confident in the way that, you know, we've developed this program at the hospital. And I think that the patients, I think I've gotten better explaining it to the patients too, and it makes them feel more comfortable with what's happening also.
We hope these OTs across various practice settings have helped to give insight into how they incorporate conversations about driving and their approach to identifying and addressing driving risk. It is the role of all OTs to address driving risk, collaborate with referring physicians, and to know how to and when to refer to their patients to driver rehabilitation specialists.